Thank you. Good morning. So what I'd like to do today is to give you some introduction into some of the issues that come up as we do research abroad, mainly talking about research done in low to middle income or developing countries and some of the concerns that arise because of that. So what I'd like to do is, of course, ask questions as we go along, or if you don't feel comfortable doing that, you can wait until the end, but we should have plenty of time at the end for answering some questions. All of our research that we do here and abroad always comes back to the participants. So I like to start off and end with all of you thinking about the participants who are in your studies. So here's an example of two participants in one of the big studies that I did while I was in Uganda. And I want you to think about this woman and her husband as we go through the talk. So the woman in the background there kneeling, her name is Anna. She's 24. At the age of 16, her parents married her to Deo Gracias, who's the man on the left. And in return, they were given 10 cows. She is his third wife. He and wife number 1 are both infected with HIV, but he is not yet eligible for antiretrovirals by the national guidelines in Uganda. They live near the Kenyan border in eastern Uganda. They make about 40 cents per day selling chicken eggs. Deo's other 2 wives have between them have had 12 children, but only 8 have survived. Anna, of course, now that she's married to him, is expected to have children, but she doesn't want to get HIV. The couple wants to consider enrolling in my study, in our study, which has to do with the prevention of HIV between discordant couples. They only speak a language called Japadola, which about 10,000 people in the world speak. They can't read or write very well. They're loyal to their king, the king of the Adola people in eastern Uganda. And they live about 50 kilometers from the closest road that a car can drive on. So the only way to get to this hut that they live in is either to walk or by bicycle or by motorbike. They do own a cell phone and they own a bicycle and pretty much nothing else. So this is the couple, this is the setting that many of you who work in the international world know. When we're dealing with what are the ethical issues, what are the regulatory issues, what does the IRB need to think about, what do researchers need to think about, we need to think about these participants and this sort of study. The woman on the right is Connie Kellum. She is the coordinating principal investigator for the whole study. She comes from the University of Washington. And the woman in the middle there is our educational outreach coordinator for the study. So I'm going to tell you a little bit about that study just because it will give us a frame for some examples as we go through the ethical principles. The study had to do with giving antiretrovirals to the negative partner within a discordant couple. So heterosexual couples where one person was infected with HIV, the other one was not, and then providing the negative partner with an antiretroviral to see whether or not you could prevent the transmission of HIV in that way. Some of the difficulties when working overseas have to do with just the multiplicities of people and agencies and groups that are involved. You may have research done here where you think it's very difficult because you have to work with our IRB and you have to work with maybe your sponsor and your department, but just multiply that multiple times, typically if you're working on a multi-center international study. For this one, we had about 4,800 couples. It was done in 2 different countries, in Uganda and Kenya, both of which have different laws, regulations, cultures, expectations. 9 different sites, 12 academic centers, both African academic centers, Canadian and United States. 11 different languages is what I counted up. 6 different languages in just the towns that I was working in. More than 20 IRBs for the study, each IRB doing independent review. And there were 3 national drug authorities. So the Food and Drug Administration in the United States, the Ugandan National Drug Authority, and the Kenyan National Drug Authority. So think about, as you're thinking about doing international research and what the issues might be and reviewing international research, all of those multiplicities. So let's just give a little introduction into some of the issues that come up with international research. One is what people call the 1090 gap. So it's said that only about 10% of health research dollars, global health research dollars, are used for the 90% of diseases that we find internationally. In other words, 90% of health dollars are put into the 10% of problems that we see in the developed world, and the flip for the developing world. So not a lot of money until pretty recently was going into the major global health international problems. In 2011, clinicaltrials.gov, any of you do clinical trials know that you have to post your trial on clinicaltrials.gov. 2011 was the year that overseas studies took over domestic studies. There are more posted overseas studies now than there are domestic studies. Just the word global health, international health, has only in the last 2 decades or so has become a very important part of our vernacular. As you probably know, most academic centers now have a global health department, division, international health group, something, which was not the case not that many years ago. The CDC that I worked for did not have a group called Global Health, now has something called the Center for Global Health. President Obama is the first president to have a, quote, GHI, Global Health Initiative. The #1 undergraduate degree program at Johns Hopkins University is not engineering, it's not literature, it's public health. So global health, public health, international health are becoming of great interest to people. There was little money, as I said before, in doing global health, but now with the Bill and Melinda Gates Foundation, with groups like PEPFAR, Wellcome Trust, Fogarty, and others, there's more and more money being put into international health. And drug companies, pharmaceutical companies, are now putting a lot more effort into, one, developing drugs, vaccines, and interventions for the developing world, but also doing their studies in the developing world, sometimes for good purposes, sometimes for what you might think of as more nefarious purposes. And just to give you a little spoiler on the entire talk, most of the topics that we're going to discuss are really the same things that we discuss for domestic ethical regulatory issues, only they get somewhat magnified and there are some kind of twists and turns that occur because of doing them internationally that I'll try to highlight as we go through. So what do US IRB members fear when they look at international studies? Well, there was a study done by a gentleman, Dr. Klitzman at Columbia, and he interviewed 46 IRB chairs, directors, and members, and asked them, when you review studies that have to do with low and middle income, developing world, international studies, what are you worried about? And these are the top things they were worried about. One is the lack of local knowledge. Here, even if you're not an expert in one field, let's say of medicine, of social work, of psychology, you still feel like you know the local context of the United States, of Baltimore, of Maryland. But when you, as either a researcher or a reviewer on the IRB, someone presents to you something that's going on in Burma, in Myanmar, you just don't have the feeling like, I understand what the interactions are. Who's in charge? How is consent done? What is the local culture? All of that. Standard of care. People are very worried about not understanding the standard of care. Here it's very simple to say, well, we get the expert in cardiology to tell us what is the standard of care for this particular heart problem. You don't necessarily know as an American researcher or as an IRB reviewer or a staff on HRPO, well, what's the expectation of both the doctors, the other health professionals, and the patients within whatever country it is that this research is being done in? There are very different views about autonomy, about how voluntary it is when people say yes. In other words, if you offer for someone to be in a study and they are saying they will or will not be in the study, how much of the choice is theirs? And it's a very important part of our culture to say that you make that choice all by yourself. It's not always that may not necessarily be the case in every country or every culture in the world. How to deal with that and still have informed consent is a big issue for international research and something that IRB members are afraid that they don't understand what those issues are. What are the different risks and benefits of daily life? Having described Anna and Deo Gratias, you may or may not really have ever experienced something like that. 40 cents a day, 3 wives, selling women for cows to be married. Those sorts of things are the norm in a lot of the world, and to try to integrate research into that can be quite tricky. Corruption. We have corruption everywhere. You know we have corruption here, but you may be worried about additional types of or corruption that you don't feel like there's oversight of in the third world. Who's telling who what they are allowed to do and not allowed to do? Where is money passing? Where are benefits passing that you may not know about if you're reviewing it on our IRB or if you're a researcher going into that country? Sustainability. What are the prospects of whatever the research that's being done that it will be used after the research is over? You have the feeling that most things that we do here domestically, that there's a train going on of basic research to translational research, clinical research to public health measures or individual measures. How sustainable is the work that's done internationally? You as a researcher, you as an HRPO staff person or IRB member, knowing about how the work can move from the research into actual practice, it doesn't always work as well internationally, and IRB members fear that they don't understand that. Compensation. What's the right amount of money or other compensation to give to participants? You may feel like you have a handle on that here as a researcher, as a coordinator, whatever your role is, but you may have no idea what would be appropriate in the international setting. Right now, 113 of the 196 countries in the world have at least one IRB. That wasn't the case a few decades ago. So most countries now have at least a single IRB, and many have multiple IRBs. Other things to think about when research is done overseas is we try at our IRB to have a mix of different gender, of different expertise, all sorts of diversity as much as possible within that body. If you look at the makeup of IRBs in the developing world, it tends to be almost all males. So if you're doing research that includes women, having that voice for women on the IRB internationally, we have to think, are women being protected, or is a woman's voice in the discussion? So those bring up probably the things that many of our IRB members, HRPO members, and researchers would be worried about, but as you can see, there have been people who've done studies on this, and things for us to think about as we do international research. These are like the 3 main topics that I'd like to discuss with you. First is just what I call the hierarchy of norms, just to give like an overview of the ethics or the regulations that go into all studies, including international studies. And then the issues, a few of the issues about clinical research in low resource countries, some words about exploitation, and then what in a very nice article by Dr. Emmanuel, the benchmarks of international research. And then I want to end with probably the hottest topic, or the thing that people discuss the most, and that has to do with the standard of care debate. So first, talking about what I call the hierarchy of norms. This is my putting together of some of the topics within the ethical framework of doing research. And if you think up the very top, we're talking about universal issues about ethics and philosophy, moral theory, principles, like the Belmont Report and the 3 principles. The higher up you go in this hierarchy, the more we would consider it universal, that all people, all research here in the US, in Europe, in the developing world, would all probably, for the most part, agree to those principles and morals. As you go further and further down to codes, reports, guidelines, conferences, laws, sponsor standards, institutional standards like our IRB, our University of Maryland standards, all the way down to standard operating procedures. You get more and more specific, more and more practical. Hopefully these all fall under and are sort of speaking to those ethical principles, the overriding principles. But they may be quite different in the way they interpret them place to place. University of Maryland, Johns Hopkins, Duke, other places have different ways of approaching these things, but probably, hopefully, all of them are using the same overriding moral theory and principles. So let's go through just kind of an overview of where those principles come from. As you probably know, before the Second World War, there really were not principles about, there were lots of ethical principles, but specific ethical principles for human subject research, there were none. And after the Nazi war crimes, there was the Nuremberg Code. And the main thing that came out of that had to do with informed consent, that you could not be put into research unless you said that you were willing to be in the research, and that there was no fraud or deceit or duress, and that the risks would be minimized relative to the risk would be justified relative to the benefits that would be received, that you wouldn't cause deliberate harm, and that people could say they wanted to stop if they were in the research. Later on came the Declaration of Helsinki in 1964. There have been 7 revisions since then. The last one was just last year in 2013. This is a document by the World Medical Association, and it expanded on some of those principles to talk about things like vulnerable subjects and legally authorized representatives and who needed to assent if they could not consent to being in a study, and things about protecting the life, the health, privacy, and dignity of the subjects. Privacy, confidentiality, oversight of the research, all of those things started to come into play with the Declaration of Helsinki. And for international research, people will usually say that they follow the principles that are outlined in the Declaration of Helsinki. In the United States, some years later came the Belmont Report. And that, as you probably know, has these 3 principles. The respect for persons, which mainly has to do with autonomy, saying that persons can decide for themselves if they want to be in research and can leave research whenever they want. And then beneficence and non-maleficence, and justice. And by justice, we mean what's called distributive justice, which means that we expect that those persons and those communities that take on the burdens of research will also have some prospect of taking on the benefits of those research, both the individuals and the communities. Does anyone know what this picture is? Raise your hand or speak loudly. Anyone? Julie? That's the Belmont Conference Center. That is in Elk Ridge, Maryland, about 15 miles south of here, and I can walk there from my house. So for all of you who probably hadn't really thought about it before, the Belmont Report, Belmont Center, right here in Maryland. CIOMS is the Council for International Organizations of Medical Sciences. Essentially what CIOMS, this book, which is the International Ethical Guidelines for Biomedical Research Involving Human Subjects, and the last update was in 2003. Well, CIOMS essentially represents the biomedical scientific community. It's a non-governmental, non-profit organization. It was started in 1949 by the World Health Organization and by the UN. And as I said, they publish these guidelines on international research. It's about 60 pages long. And the way you can think of this is like an operationalization of the Declaration of Helsinki. Declaration of Helsinki is very short. It gives principles. CIOMS and this code gives much more detail about how those principles should be used within the international community. So what are some of the main issues and controversies in the recent years? The standard of care controversy we're going to talk about at the end. That has to do with what is the appropriate standard for the control group or for anyone who is in your research internationally. Is it the best standard known? Is it the best standard within that country? Is it the best standard locally? What is appropriate standard of care when we say what the standard of care is? And that debate continues to go on. I'll give you a little bit more insight into where that debate stands and my thoughts about where we should set the bar for the standard of care. Second has to do with reasonable availability. Many of the guidelines talk about after research is completed, there should be reasonable availability of whatever it is you find in that research. So if I find out that pre-exposure prophylaxis, that giving antiretrovirals to a negative partner in a discordant couple prevents that negative partner from getting HIV, what are my responsibilities as the sponsor, the drug company, the researcher, the institution, to those individuals who are in the study and to the community that was in the study in terms of reasonable availability of PrEP from there forward? Am I obligated to provide them antiretroviral protection for a year? Not at all, and hope that the Ministry of Health there will provide it to them for the rest of their lives if they're in my study? Not just to the people in my study, but to the entire community that took on that burden of the study? What is reasonable availability? This is something that you as a researcher should think about if you're doing international research. And we as IRB, HRPO members, staff should think about what will happen when the study is over. What sorts of obligations do the institute, the sponsor, and the researcher have to the participants and the community? It's not an easy answer. There's not a cut and dry answer, but it's a question that should come up as you think about that research and review the research. Quality of informed consent. How good is the informed consent? How is the process being done? Our processes here may be quite different than the processes in low and middle income countries. What questions should we be asking the researcher? What should you as a researcher be thinking about when you're doing informed consent with someone who is illiterate, someone who doesn't understand necessarily what randomization means, what chance, what research means really? The therapeutic misconception, we're all worried about that here, where participants who are also patients might think, because you're a doctor, because you're in the health profession, me getting into research may feel like I'm going to get medical care. Well, whatever that amount of therapeutic misconception might be here, multiply that in Uganda or wherever else you're working, because the people there may have even less access and less thought about that and never seen any research before, never read something in a newspaper or an article or seen something on TV about the newest vaccine or the newest drug. They don't think that way. So how do you prevent them from having the therapeutic misconception? Much more difficult and a bigger burden on you as a researcher and on us as an IRB when we review. Every ethical guideline, every one of those principles, anything that has to do with international research, one of the main points of why we put extra protections on is to minimize exploitation. The definition of exploitation, there are lots of definitions, but one might be to think about unfair level of benefits or unfair burden of risk to a particular group or particular persons. Why are we not as worried about exploitation in the US? Like I said in my spoiler, everything we're worried about internationally, we're worried about in the US, but to a greater degree internationally. We'll think about some of the things that might lead to increased risk for exploitation, or in the US situation, decreased risk. In our situation, in our society, we fund research to improve health. It's part, you just expect it. Your tax dollars go and fund the NIH. Your idea about what occurs in health has to do with both care and that there's this churning of research going on. It's the expectation, it's part and parcel of our society. It is not like that in Uganda. The Ugandan government does not have a way that you write for a grant to the government to get money to do your research. They don't have NGOs there and foundations there. They don't have other groups that are providing funding. That is not the expectation. So when an outside group comes in and says, we have lots of money and what we want to do is test this hypothesis, it's foreign to them. There's much greater risk for exploitation in those situations. Researchers and research institutions are part of the community. If you live in Baltimore, you know there are medical academic centers here. You may not completely understand what research is all about, but again, you hear on the news, it's part of what we do, that there's movement in care, in healthcare. And people hear about, oh, that fancy new thing, oh, I heard about stem cells, I hear you can do this with a spinal cord. That is not part of what people, for example, in Uganda have in their mindset. Much higher risk of exploitation for people that if they don't think about that day to day, it's easier for them to be exploited. And not only, when we talk about exploitation, we're not only talking about the participants, we're talking about institutions, and we're talking about researchers, overseas researchers who make this much money, and you come in with this much money, there's definitely the risk that they may say, I'll do anything because you're going to pay me 10 times what I can be paid in the public health sector here. Not thinking about necessarily about the risks to their people, to the participants. Here in the US and other developed places, there's an infrastructure that, even though it's not perfect, it does translate research into practices. You have the expectation that what you're doing, even if it's in a very small way, leads to improved health in the people in the United States. Benefit to the community, benefit to the participants. That's not always the expectation in the developing world. You would hope it would be, but it just is not part of the mindset, and sometimes that could then lead to increased risk for exploitation. People in low and middle income countries are poor. They have limited and sometimes very limited healthcare services. Ana and Deo Gratias, the only way that they can get to a very small healthcare center. We're talking about very small. With no drugs there, no vaccines except on special vaccination days, no doctors. The closest doctor is about 100 kilometers away, the closest physician. The closer you get to them, you get people lower than, who are not as well trained as doctors. So there are some clinical officers maybe 75 kilometers away. There are some other health trained people, like first aid type people, very close to them. So for them to get full healthcare services, to get antiretrovirals, they have to go a very long distance. They have no money. No one can get them there. They'll only go for those health services if they're very sick. They're illiterate. They have cultural and linguistic differences from us. They have limited understanding of the nature of scientific research. And regulatory oversight can be less developed and usually is very poorly funded. Even in places where I've been, where the IRBs in the developing world, where the IRBs have very well-trained people and people who think in ways that we would expect you would think that have to do with protecting the participants and all of the issues that we talked about, they typically are very poorly funded, and it's difficult for them to get their work done. They're given a very small office. They have no place to file anything, no electronics, one person that's a secretary trying to deal with all of these researchers that are there. It can be quite challenging, even when you have people who are able to think through the ethical issues quite well. All of these things, those bullet points there, are neither sufficient nor necessary for exploitation, but they all increase the probability that people in the developing world could be exploited. We always need to think about what people call neo-colonialism, and that is, there is obviously a history in many of the places where we go of slavery, of people having been colonized, of being exploited in many other ways in the past. And we don't want it that now, even if we're not enslaving them or truly colonizing them, that we're not going there to medically neo-colonize them, and that is to use them for our medical purposes. Okay, these are the 8 principles put forth by Emmanuel on clinical research in developing countries. And if you heard Dr. Rosenthal's talk not that long ago, they're very similar to the ones that have to do with developed countries. But underneath them, he has written benchmarks, issues within these that make them somewhat different from the developed world. Number 1 is the collaborative partnership. In the US, we don't think of that very much. We don't think that we need to have a collaboration a little bit between the researchers and the sponsor, but not between a host country and the sponsoring country, not between me at the University of Maryland and the people that I work with in rural Uganda. That collaborative partnership can be a way to decrease exploitation. It means that the country where I'm doing the work, Uganda, that they get to decide, is the research responsive to their needs? It likely leads to a more lasting impact. If I go in with my ideas and there's no collaboration, chances are I haven't thought through all the things that might lead to the sustainability. But if you're working together with researchers, public health officials, and others in country, more likely you'll have a lasting impact. Mutual respect for cultural differences. When you work overseas, you realize you think that it's very easy to be very Americocentric, where you think we have this and then all these people are different, but what you realize is all people are different. We have cultural things that they have to put up with, and they have cultural things that we have to put up with, and working that back and forth becomes a very important part of the collaboration. Shared responsibility. Typically, what can happen in what you might call helicopter research, where people fly in, do their research, and then leave, is that you don't have shared responsibility. The researchers in country have to take on authority and responsibility. It can't only be the American researcher that's doing the work and taking on all of the responsibility. When we work overseas, we aspire to minimize disparities. We cannot remove all of the disparities in healthcare sophistication and healthcare access, but we can aspire to minimize those disparities, especially within those related to the project. In other words, if we have the ability in the United States to have some level of prevention of HIV, and that level is lower in the developing country that you're working in, you're aspiring to get it closer to the level that you have here. And then a fair distribution of the rewards of research, not just for the individuals, but for the community. And not just that now they're going to have antiretrovirals for prevention, but do they now have a better IRB? Do they now have researchers who can get independent funding for future HIV research? Do they have a better computer system that now allows them to collect data for future health-related research? All of that benefits the community. It doesn't work if you helicopter in and out. It works if you set up collaborations, collaborative partnerships with your international groups. Just like in the United States, there has to be social value. We don't want to be doing research that doesn't lead to good. Cui bono, that means the good for whom? It's like a law phrase, a Latin phrase, who gets the good? If only we benefit, or if mainly we benefit, and not the place where the study is being done, it doesn't fit within the ethical guidelines that we're discussing. We have to think about what the importance of those health problems are. Enhancing social value, not just, as I said, through the primary outcome of your research, but also through dissemination of knowledge, through development of products, long-term research collaborations, and improving the health systems. The other thing that is difficult to do when you work overseas is to make sure that you don't supplant the extant health system. It's relatively easy, and this happens a lot, where people go in and say, it's so important for me, I really want to fix your malaria problem. And so I come into your country and my researchers and I kind of take over the system. We have a lot of money, you have very little, and we kind of take over and say, we're going to do everything our way and show you that it can work. When you leave, it's not going to work. You have to work somewhat within the health system, even broken, in order for you to expect that over time, that research is going to have an impact on the community. Some of it is, yeah, you can raise up the health system, but you can't all of a sudden come in and plop in an American health system, say, it worked, look, we can do this, and then leave and go back to the old health system. Usually that will not work. Dissemination of your results, as it says there. How do we disseminate our results here? all of you are expected when you're done, you'd say, well, it's unethical if you didn't publish it, if you didn't present it, if you don't have a poster, an abstract, if you don't tell people about what you did. That doesn't work. That's not enough in the developing world. We don't typically go to our communities here. When I'm done with my next vaccine study, I don't go out to the city of Baltimore and say, okay, we want to tell you what we did here. And all of you probably do your research. There's not a lot of community dissemination, except it gets out to a newspaper or to a media outlet. In Uganda, we had couples groups. We met with them and said, here's what we know so far about couples and preventing HIV. And over time, we kept giving them more information. We had community advisory boards, people in the religious realm, in the political realm, in the health systems realm. All of them, we had to disseminate those results. We had to go back to the Ministry of Health. Tell them what happened. Go back to the IRB there. Tell them what happened over time. Dissemination of results can be quite different, and if you don't understand that, you're not going to be able to continue to do the research in that country that you're working in. Nothing works unless it's scientifically valid. You have to think about the design. Does it provide social value for the beneficiaries of the research? Does it meet the objectives while allowing the participants to get their usual health care? And is it feasible within the local context or with sustainable improvements? That's not an easy thing to look at from the outside. You don't want to keep that country or that health system exactly where it is. You want incremental benefits, is the way I look at it. If you try to shoot all the way up here, they're not going to be able to jump all the way up there right away. But if you say, we're working together for incremental benefit for this community, those are sustainable improvements. Those are expectations that I think fit within the ethical guidelines. Fair selection of study populations. This is justice. Of course, we talk about this in the developed world, but you have to think about this even more when you're in the developing world. Like picking places where there's a high prevalence of whatever the problem is that you're studying. Looking to minimize the risk, maximize collaborative partnerships and social value. Vulnerable populations. We have a list here that we consider vulnerable populations. You have to think and ask people who work in that community, who are the marginalized, the politically powerless, the economically disadvantaged within the local context. You may not realize it. Homosexuality is illegal and potentially capital punishment in Uganda. So talk about marginalized. I mean, we may think of men who have sex with men to have some amount of marginalization within the United States. Nothing compared to Uganda. How do you protect that vulnerable group? It's different, the protections you have to put in place. Women do not have the same political, social power in many circles, in many cultures. How do you still protect them? Plenty of other marginalized people you need to think about. In Uganda, we also had, for example, certain ethnic groups that were considered marginalized, and you needed extra protections for those people who spoke a different language, who came from a different country, et cetera. Favorable risk-benefit ratio. We need to assess the risks and benefits in the context of that sample's health risks and assess the net risks and the net benefits, not just the individual risks and benefits. The use of placebos is a very important topic that comes up here, but even more so overseas. When is it appropriate to use placebos? It's not easy to give. There are articles written and lists that you can kind of try to go through to say this might be acceptable or not acceptable to use a placebo. I'll give you the example of that study prep that we did. So we had people receiving, those negative partners receiving antiretrovirals, but some of them in a double-blinded fashion were receiving placebo. So this topic came up ethically among the IRBs. Is it appropriate for us to provide placebo, nothing, a pill that looks like something but has nothing in it, to a group that's at risk of getting HIV? And our argument was, we will provide all the couples with a standard of care that is internationally, that we all agree upon, that would be an acceptable standard of care. Some of them would get on top of that PrEP, which may or may not protect them, we don't know yet, and others would get placebo. And if we find that the placebo doesn't, that the PrEP works, that the placebo members will then be switched to the arm that gets active drug. That is a way, a design, a potential design, that placebos, I think, are an acceptable way. But you have to look at each individual study to kind of decide, is placebo acceptable for that study? Independent review, public accountability through reviews mandated by regulations. We are, as you probably all know, maybe over-regulated here in the United States. The number of rules that we have HRPO rules, institutional rules, sponsor rules, NIH rules, OHRP rules, FDA rules, rules. You go to other countries, those rules are either not well written, not there, they're using somebody else's rules, not understood by people. There's a lot, or not enforced, which is a big problem, where they just take somebody else's long list of rules and then nobody looks at them. All of that is an important thing for you as the researcher and for us as IRB members to make sure that we understand and that we hold ourselves accountable to following through. Public accountability through reviews by international NGOs as appropriate. Sometimes we need outside organizations to review things to give credence to what we say. In other words, I just told you about that standard of care that we were using with the placebo. We thought the best way, our researchers thought the best way to come up with that list, what is the standard of care or what should be the standard of care, is to pull together research, people who work on HIV internationally from the countries we were working in, from the WHO, from advocacy groups, from researchers, couples, everyone, come up with the standard of care and publish it. Say, this is what we think HIV prevention care should be like. If you're getting a placebo, you have to at least get all these other things. If you're getting a vaccine or you're getting a PrEP or anything else that's HIV prevention, what should be the standard of care? That then gives buy-in for many people into that issue of standard of care, and it's not just one researcher, one IRB, or one country and one researcher. Making sure that the reviews are independent and done by competent people is not always easy. And building up, improving IRBs where we work as international researchers, I think, is an important part of what we do. Informed consent, involving the community in the recruitment and in how best to recruit people and what incentives are appropriate. In other words, can you pay people? Should you ever pay them? How much should they be paid? Money or something else? Is it appropriate to give them something other than money? Disclosure and consent, doing things culturally and linguistically appropriate. In some cultures, it would not be appropriate for us to have a couple, a man and a woman, discordant HIV couple, and to say, I am independently going to speak with the woman, and me, the researcher, I'm a man, and talk to her about sexually explicit issues, about her sexual practices. That may not be acceptable. You have to know that before you're in that situation and try to figure out how can we get that information if it's necessary for our study and still be culturally appropriate. Supplementary community and familial consent, what people call spheres of consent. This is a sticky issue in international research. Some people have talked about what's called community consent, in that there are places where the tribal leader, the leader of a nomadic group, for example, they make all the decisions for everyone in that group, all the decisions. So if you come and say, I want to do research there, and I want to individually ask all the people in your tribe whether or not they're willing to be in the study, that person may say, I make all the decisions. How do you deal with that? How do you deal with somebody who says, I do the consenting? Not my wife, not my family, not all the people that live with me. It's a difficult situation. And what most of us would believe is that we still need individual consent, but we would first go to those leaders to get permission to get that individual consent. So what's called spheres of consent. Permission from whatever that group is, and then drilling down to the individual. And every place, almost every place that I've worked internationally, this has been the case. I cannot go in there as a University of Maryland researcher, show up in Tororo, Uganda, and start consenting people. I need to go to the mayor. I need to go to the head of the public health group there. I need to go to religious groups there. I need to go to whoever the local people tell me are the ones that I need to talk to before we can do this and come up with a collaborative partnership. It just doesn't work otherwise. Here in Baltimore, I don't have to do that. I just put up flyers and people show up. Can't do that in many places in the world. You need to ensure that people have the freedom to refuse or to withdraw. Has there been any research on this? Yes, a little bit. Informed consent, is it worse in developing countries than in the US? This is an article by Mandava about 2 years ago in the Journal of Medical Ethics, analyzed studies of consent comprehension. And as you might expect, there was wide variation across all the studies. They looked at both developing and developed world. And you can see those 3 bullets there. So overall, in both the developed world and the developing world, people tend to, if you do a good consent process, they tend to understand the overall purpose of the study, what the risks might be, some things about the study logistics and details, like when they're going to get their blood drawn and how many times they have to come back for follow-up. But both in the developed and the developing world, they tend to poorly understand things like randomization, chance, allocation, design of the study. All of those things, we can't get our participants to figure them out. We can't do it in the developing world either. So I don't think we should try at this, I mean, we always want to try to level the playing field, but don't expect that just because people in Uganda don't understand what it means to have a 2-to-1 ratio of randomization to placebo to active, people here don't understand that either very well when studies have been done on it. But what is a little disturbing in this study is that in developing countries, the participants scored more poorly on the voluntariness and the withdrawal aspect, and that they didn't understand that it's completely voluntary to be in the study and that they can leave the study at any time. So those are things, as part of an international researcher, if you want to beef up how well you do informed consent, I think focusing on that is an important issue. The last topic in the Emmanuel article has to do with respect for persons and communities. We tend to say respect for persons. As I said, we're a very individualistic society. In the developing world, you need to think about respect not just for the individual, but for their community. How do you protect confidentiality? That can be a difficult thing. For my prep study, when we originally designed the building where people were going to come, they had to walk through the hospital health center area in order to come to this building. What do we put on the building? Do we put, this is the building where the people with HIV come? Okay, well, that is a problem, right? Because there's some stigma there. So our building said partners research or something like that. It said partners. So most people, unless they're asking, they don't really know what that means. We had to put up a big fence with a hedge. We felt we didn't have to. We decided that would be the best thing. So when people came onto the campus, they would then go inside this area, and even though they were sort of sitting outside under an awning, not everyone that walks into the hospital will be able to see the people who are waiting to come in for our research. How do you protect electronics there? I mean, here we have a lot of ways of making sure that people can't hack into your electronic database. Difficult in Uganda. Same with paper. Things are not as easily kept confidential. Provide new information after the study starts. We talked a little bit about that. That's very important. While I was doing my PrEP study, I think 5 other HIV prevention studies, some that had to do with PrEP or with microbicides or other things, came along. Each time we had to come up with a way to tell all of our couples, this is what's new. Do you still want to be in the study? Evaluate for medical conditions and develop interventions at least as good as the local norms, and inform the participants and the study community of the results, as I already talked about a little bit. So then the last thing is this standard of care debate. And this is my little illustration of the way I think of it. So we're going to go all the way from, it's a continuum of what the standard is. And we might say that the worldwide best, not necessarily, but maybe this is very America-centric, but let's say the US de jure. De jure means of the law. So the norm, the expectation, like what's written in the guidelines by whoever makes your guidelines, that would be the US de jure. US de facto is actually what happens in the United States. Now, typically we're going to follow the guidelines pretty well, but maybe not completely and not in every community. But still way higher than as you go down the line here. If you're talking internationally, WHO often comes up with their guidelines. For example, for PrEP, it was HIV. WHO said, here's what we expect countries to do for HIV. So that would be like the de jure WHO way of taking care of HIV. Then Uganda has national guidelines for HIV. Not always followed, and especially not followed when you get all the way out to places like Tororo, that first picture I showed you here. So you've got Uganda Best de facto, which would be, let's say, like the top NGO, the best HIV care group within Uganda is doing things as close as they can to the national guidelines because they have funding, because they have people, because they get antiretrovirals, all of that. And then you go all the way out to the place I just described to you, 50 kilometers from the closest road. These people don't have any antiretrovirals, no access to HIV testing, no viral loads, no phenotypes, no genotypes, no anything, any of you who work in HIV or anything else, think of the best things that we do. They don't have any of it. So if I say, well, what's the standard of care? Now I'm going to put these people in my study. Is it their standard, what they have all the way out there, which is essentially nothing? Is it, let's say, the best in Uganda, if they went to the capital city and they had the access to that? Or is it the Ugandan national guidelines? Or is it what WHO says? Or should we say the only way I can do research there is if I provide them this? Viral loads every quarter, phenotypes, genotypes, CD4 counts, the best antiretrovirals, all opportunistic infections with the top drugs that we can treat those opportunistic infections with. If we were to do this, my feeling, even though there are some people who still believe this is the case, if we were to do this, we would do no research in the developing world. We couldn't. And what would we leave them with? We would leave them with the ability to, if we move them to the United States, they would know how to get care. But what we want to do, in my mind, is to bring them up from where they are somewhere further in a reasonable amount. So I think it's somewhere in here, the best, and this is what we shot for, somewhere in the WHO to Uganda best. So even though these people do not have access to the best where they live, we think they should have at least this. So the standard of care, and many people would consider this a reasonable place to put the standard of care, is somewhere there. There's a group called the Nuffield Council, and I like the way that they put it. It's provision of those treatments that the community endeavors to provide nationally, even if the community actually fails to fulfill its own standards. And again, I said that that a lot of these things are very similar to what we have in the United States. It's like that in the United States. We do not necessarily provide the very top best of care for everyone in every research protocol. We provide the best we can. And I think that is a reasonable place to go. But you have to think through that hard and long, both on the IRB side and on the researcher side, when you're doing studies internationally. These three things, all of these ethical principles, when talking about standard of care, say, and if you're not giving the worldwide best standard of care, you need to make sure that it's valid science, that there are social benefits to the host community, and a favorable individual risk-benefit ratio. So that brings us to the end of the road. This happens to be an actual end of the road in Ethiopia when we thought we were going to drive up and do a serosurvey, but we had to walk the rest of the way. And to the end of the talk. And I want to just bring you back to those two people, to Anna and Deo. Because again, I think about when I'm doing research and when I'm reviewing things in the IRB, what would it be like to be Anna and Deo, those two people in the study? So you need to think about those controversial issues whenever you're doing studies. Are we exploiting the institution, the researchers, or the participants? And how are we preventing exploitation? Are we offering them fully informed consent? Is the standard of care that we're offering adequate? And are you doing all that you can do to assure that they and their community will benefit from your research? And go back to those 8 principles. Is it a collaborative partnership? Is there social value? When you leave, will things be better than when you arrived? Is it scientifically valid? Is there fair selection in the population? Do you have a good risk-benefit ratio? How assured are you of good independent review, that the consent is informed, and that you're respectful of the participants and their community? So I want to thank you for listening, and then just make some acknowledgments. to the Centers for Disease Control, to the University of Washington. TASO is the HIV group that I worked with in Uganda. The Ethiopian Ministry of Health. All those pictures that you saw, including this last one, are from Ethiopia. CVD Mali, where I've worked quite a bit, our HRPO and IRB, all of my CVD colleagues, Dr. Rosenthal, Jarrell, Edelman, Silverman, and Shamu, and to all the participants in all the studies. And now I'll take questions. Yes?
When you obtain consent from the chief or the leader of the community, how do you handle when an individual refuses your community? Is there a risk of reprisals if they refuse to participate in voting that consent?
Yeah, there can be, and it has to be something that you have to figure out prior. You don't want to go into the situation not understanding how that works in the community. And that's why having that collaborative partnership, you'll understand that prior. If prior you know that individuals cannot autonomously by themselves make decisions, most people would say you can't do the research. From our point of view, you cannot do the research there. But if prior you discuss with the leaders and say, if you know from your local collaborators that it's possible, and then you go in and speak with the leaders and say, we know that it's important that you make the decision first whether or not we can come and work in your community. But it's also important for us that everyone in the community gets to say yes or no. And in situations where people can't say yes or no, unfortunately, my opinion would be that you just can't do the research there. And you could find other people probably who have that similar risk, similar prevalence of the disease or whatever, who would be able to individually at least dissent from being in the study. Bob?
Jim, would you tell us something? You wrote it and done it for 5 years. And you have a lot of hurdles to overcome to get your study started. You made that very clear. How long additional time would you approximate one would need, in your case and maybe other situations, to get a study after the first go see something together versus the United?
Well, it really does depend on the study. For our study, it took a long time. It took 14 months from the time that I arrived until we had the first person enrolled. And that had to do with building infrastructure, teaching people the SOPs, going out into the community, figuring out how we were going to recruit people, getting ethical review, a lot of work prior. But if you already have the infrastructure there, if you've been working in that country for a long time, and if you have a simpler study, then it's not that much different once you're established. But the getting established within that group and knowing who to talk to, how you're going to, a community advisory board, just putting together a community advisory board can take quite a while. We already had a community advisory board from a previous study I was doing there, so we used the same one. That made things a little bit faster. We knew which ethical committees we would be using, so that made things a little faster, but still it was 14 months. Yeah?
Related question regarding the local culture. You're introducing some, quote, Western concepts in terms of authority for signing informed consent, etc. What kind of pushback did you get from the authority figures there? And when you left the country, could you say that they, quote, improved the processes, or did it revert back to the old?
Yeah. I'd say the main issue having to do with informed consent, well, of course there was literacy and witnesses and things like that. But one was the amount of time. It took us 3 hours typically individually to go through informed consent with people, and there were multiple sessions, but one main 3-hour session to describe the study. And it's not that complicated of a study. It would have taken us a lot less time to do it here. Signatures was a big issue in Uganda. Most of these people, they sign their name 2 or 3 times in their lives, and they consider those the biggest events in their life. Not like us, where I'm signing things constantly, and I think something about my signature, like, okay, I said I'm going to do that or whatever. There, it's like you get married, you transfer property, and I don't know what else. Only the biggest things. So for us to come in and say, well, this isn't that big of a thing, you're just in a research study and we're going to see if this happens, and we want you to sign, they would say, no, like we don't sign. So thumbprint was acceptable. Signing, most people didn't want to sign. But going through that, having a community advisory board, having people that worked there already that knew that that was an issue, it made it a lot easier for us to be able to say, we understand that, but we just want, all we're doing is asking, are you willing to be in the study? Are you willing to do this? And at any time you could say no. They felt like signing, it was over and done with. It was a contract. And in terms of are people better off, I mean, one thing that we did that I was sort of proud of is that we knew that in the community, the rate of transmission of HIV among discordant couples was somewhere between 10 and 15 per 100 person years. So for every 100 couples that went a year, 10 or 15 would transfer to the negative partner. In our study, the placebo group, that rate was 2, and in the PrEP group, that rate was 0.5. So we brought the community rate of transmission down 80% just by being in the study, by giving them the standard of care, which they couldn't get in the community. So by treating all their STIs, by giving them condoms, by talking to them about how to prevent HIV, by all the other things you might do, if you had the money and you had the resources and everything. So even the placebo recipients, before we discovered PrEP work, had an 80% reduction than they would have had in the community. So I feel like they were better off, the community was better off for that. And in terms of their regulatory issues, yeah, I think over time they, with multiple studies and multiple investigators, their regulatory infrastructure and just their thought process and ability to interact, and I think improved quite a bit over that time period. Yes? You're the only one, that's fine.
You were working with, you said 12 IRBs. Is that what you said, 12 IRBs?
I guessed, but yeah, it's about 12. Not me. For me, it was 4.
Even that. So the question I have for you is, what is your experience with getting buy-in from every IRB in an expedited way? They're all on the same page. They all know what you're trying to do. They're all comfortable with the international system. But whether, because the success of a study like this is depends upon the weakest link.
Yeah. Most, it doesn't happen like this for all studies, but for our study, the biggest controversies in terms of regulatory controversies were not us versus them. It was the 3 regulatory groups within Uganda who didn't always see eye to eye. So that's what the national, they call it the UNCST, the Ugandan National Council on Science and Technology. It's essentially like OHRP for us. And the individual IRB at the Uganda Virus Research Institute, and the National Drug Authority there. To try to get the 3 of them to agree on the way we should do things was difficult. Whereas the CDC, University of Maryland, which came into it late, but CDC, University of Maryland, and University of Washington, they all seemed to like they got it, I think, and there were some negotiations that had to occur. For example, other sites were doing STI, sexually transmitted infection, standard of care by syndromic standard of care. That's what the WHO recommends, is that someone comes in with a syndrome, you just treat them by that syndrome. No diagnostics are done. CDC said that's not acceptable. We want you to do that. You have diagnostics in country. We want you to do those diagnostics, even though it's going to cost more money. You're going to have to ship them to the capital city. So that was like a negotiation. Some sites did it one way and some sites did it another way. Kenya had a different CD4 cutoff than Uganda had. We had to adjust that through the time. But in terms of the interactions between out of country and in country, that actually worked quite well. Not for all the studies I've done, but for this one it did. Yes?
Can you speak to how you handle ancillary care in some of the places that you've done some of your studies?
Like what do you mean by ancillary care?
Like if you were doing a study with these folks in Uganda and some other health concern comes up during the course of your study, how do you have some sort of policy on how you handle other issues or health issues that may come up in these people that are separate from the HIV that you're working with?
Yeah. So we provided them with a known amount of care within our research setting, which was relatively minimal, but we did take care of some of their acute problems, relatively minor things. We came up with what we thought was a reasonable formulary within our pharmacy at each of these sites where we could care for some of the simpler things that they had. Each of the clinical research sites, though, was purposefully put within a clinical setting where we had a relationship with that clinical setting. Like, we were in the Tororo District Hospital, so we had a relationship with them, and for problems that were bigger than our little formulary, we knew all the people within that clinical setting, and we could provide them with a consult, essentially. You know, we could send them to the right people for that additional care. For HIV care, you know, I said these were discordant, so you had a positive partner and a negative partner. The positive partner, at the time we started, could not yet be eligible for antiretrovirals. They weren't on HIV drugs. But we knew over time they would become eligible, some of them, and about a third of them became eligible through the 3 years of the study. So we felt it was very important that we got them onto antiretrovirals as quickly as possible. In the country, something like 20 or 30% of people who were eligible for antiretrovirals were actually on antiretrovirals. In our study, 95% of people. So every 6 months they got a CD4 count done, and we went to them and found them to make sure that they, if they wanted to, that they could be put on antiretrovirals. So even though we weren't their HIV care providers, we were affiliated with a group that did that, and we made sure that they got into that care as expeditiously as possible. Same for circumcision. During the time we were there, it became more and more recommended that uncircumcised men get circumcised in order to decrease their risk of HIV. And so we had people there that we knew that could do circumcision in part of these campaigns for circumcision, and we could refer our male participants to those providers. We couldn't, you know, there were some people who said, you should provide circumcision for all the men in your study because it's the standard of care. WHO now has said it's the standard of care. We said, well, you know, we can't hire surgeons at each of our HIV clinical sites. We can get them to them, but we can't do that. So that was like a debate about standard of care. What is our obligation in terms of providing circumcision to the men? And we felt it was acceptable since most people in the country had not yet taken on this idea that circumcising adult men, you know, was it was a cultural issue, it was a manpower issue, et cetera. So we got all the men who wanted to be circumcised to the surgeons, but we didn't personally perform the circumcisions. Okay, thanks.